Okay, my title is Uso de la Epidemiología Clínica para entender la Uveítis y su tratamiento. So I'm sorry my Spanish isn't good enough to give the lecture in Spanish, so I'll proceed in English. And if I understand the assignment correctly, I'm trying to sort of educate you about clinical epidemiology by using sort of examples from the literature in uveitis, which I've been involved in personally with for the most part. So clinical epidemiology is an application of epidemiology to study clinical disease or clinical scenarios. And it's been called the basic science of clinical care. And it's really the foundation of so-called evidence-based medicine, which is a popular concept, although most of our clinical decisions still are made more on impression-based medicine, since evidence is limited for a number of things. But it does provide the opportunity to confirm clinical impressions and often generates insights that change clinical practice. And this is sort of what I've been doing mostly in my research career, is confirming and occasionally refuting clinical impressions. Just a little bit of information about me, since this is sort of following my trajectory. I trained in ophthalmology. I finished in 1996, and then I proceeded to a special public health ophthalmology program, which is geared, or it's not really completely existent anymore, but it was geared towards international problems, but also epidemiology, public health, and so on. And I proceeded to get some graduate degrees in international health, biostatistics, and epidemiology, as well as doing a uveitis fellowship and some research fellowships in clinical trials. And then I embarked on an academic medicine career. I started focusing on ocular complications of AIDS, which seemed to be the disease of the century. But since I was starting in '97, that was right after highly active antiretroviral therapy came along. And so it sort of became a presbyopia practice pretty quickly after that. It was delayed a little bit in Baltimore, as Armando can tell you. But even there was a lot of progress. Sort of was an unbelievable change. So I kind of refocused on uveitis. I had gotten involved in uveitis just because it was part of my fellowship, because at Hopkins, the sort of immunology fellowship included both AIDS and uveitis, and uveitis was the less studied area. I've been greatly assisted in my career by National Eye Institute, National Institutes of Health funding, and have been very blessed to have a pretty high batting average in getting funded. So I started at Hopkins. I was there for 9 years. I was a trainee for 2 years and faculty for 7 while I was finishing my PhD. And then I moved to Penn, where my wife's parents lived nearby, for about 11 years, and became a full professor with tenure there. We had always been interested in global ophthalmology, and so I shifted to trying to develop an international program in a place where ophthalmology needed development. So my family relocated to Ethiopia, where I am now, back in 2015. So it's been a little over 5.5 years. And then Penn, it seemed like they were going along with that, since I have to raise the money to support myself at all of these institutions, but someone didn't like it. And so I shifted to Mass Eye and Ear and Harvard in 2017, where I'm still appointed now, as Armando is telling you. So that's sort of where I've been. Since I'm focusing kind of on a smaller area, this has allowed me to sort of still be a clinical expert and be a key opinion leader, as well as to be very involved in research, which is not that easy to do if you have a broad spectrum practice, especially if it's a very surgical practice. I've been doing clinical care and teaching for 23 years now, and have spent much of my effort sort of applying epidemiological methods to troublesome questions of our field, and sort of generating an evidence base, which was not really very strongly developed at the time that I started as a faculty member back in 1998. And generally, what sort of sets you on the course to address a problem is just sort of when it bothers you clinically and you don't really know what to say to your patients. And so this is sort of a big source of answers to questions, and sort of by being double trained, I like to think of it as sort of sitting on the watershed, you know, the sort of the, I don't know if that's a familiar term, but to be on the top of a ridge of mountains where you can see down to the left and to the right at the same time, and sort of put the two together in order to answer questions. And so this has been God's blessing to me to be able to do that. So just to go over some of the clinical epidemiological material, it can be applied to assess sort of most of the important questions in healthcare. The burden of disease, prevalence and incidence of diseases, assessment of risk factors either for developing the disease itself or for outcomes of treatment, agreement studies and grading the extent of disease, for instance, treatment efficacy or effectiveness study, the assessment of treatment safety, and then synthesis of evidence or evidence-based review. And I've left out the Oxford evidence levels, which I meant to include, but you're probably familiar with that. The clinical trials are the highest and case reports are the lowest, and so on. So each of these is associated with a certain kind of method. So for assessing the burden of disease, you basically want to have a population representative study, usually a survey, either a questionnaire or an examination survey. To identify risk factors, you can do that cross-sectionally from a survey. You can do a cohort study, which we'll talk more about in a minute, and look at risk factors, or a case control study where you start with the outcome and you look back at the risk factors. For agreement studies, we use agreement statistics, especially the kappa statistics, and we'll talk more about that. For diagnostic test assessment, I don't have examples for that one because I can't cover everything, but sensitivity, specificity, positive predictive value, and this is supposed to be negative predictive value. Treatment efficacy, classically clinical trials. There are some ways of doing sort of simulations of trials, but clinical trial is ultimately the gold standard. And treatment safety usually is going to be a giant cohort study, but you could do a case control study for that. I don't have an example of a case control study here either. Again, even though an hour and a half seems like a long time, it probably will, I'll probably end up taking all of that time. And then evidence synthesis is an evidence-based review or meta-analysis, which is sort of a popular area now since it's sort of relatively easy, or it's not that easy, but easier than like a clinical trial, for instance. And it generates what's thought to be the highest level of evidence. So I'm going to approach these out of order because I'm going to introduce some sort of important studies early, because I kind of use the data from those studies to illustrate subsequent techniques as well. So we'll start then with treatment safety, which is sort of getting at my most famous study, and this is a cohort study methodology. So if we just think about the problem of safety, adverse events of treatments are uncommon to rare, so it's very unusual for them to affect a huge number of people. We saw a couple of instances like with Cidofovir in the AIDS situation where they were rapidly accelerating approval of drugs where a large number of people had significant adverse events. But generally, it's the uncommon to rare events that you have to worry about because the others kind of result in the drug being canceled early on. And so typically then you need a huge amount of experience, either person time or eye time. We can think of both in ophthalmology because things might affect only one eye and not the other. For instance, you need a huge amount of such experience to see if a treatment increases risk or not, both in terms of a lot of people or eyes and a lot of time. And so this makes it difficult. And usually you're looking at this like a drug is supposed to be safe and effective to be approved, but safety really isn't addressed very well in drug approval clinical trials, because especially in ophthalmology, it's only usually a few hundred people, maybe only 250 or something like that, and they're followed for 6 to 24 months or something along that line, and you're supposed to estimate side effects. It's basically impossible, except for really common side effects. And then usually the FDA or the European approval agencies ask for long-term extensions of these studies, but if it's only a few hundred patients, it's still not going to be much experience. And so often then it's really kind of an ongoing task to sort of notice if there are side effects. There's been a center at Oregon Health and Science University that receives reports about possible side effects, and these clusters of events then might provoke an investigation. And usually you need some sort of large cohort study to address it. You're not usually going to use a randomized trial to address it because it's difficult to persuade people and probably unethical to enroll them in a study where the goal is to see if a drug is toxic or something like that. So a long-term observational study or cohort study is usually the right one. And with the emergence of administrative databases, this becomes a little bit easier to do, although the quality of data are less. So a cohort study is one of the most important methodologies to understand in clinical epidemiology. The key features include that you have a defined group of people, which is where the name cohort comes from, a cohort of people or subjects that are followed over time for an outcome. And so the outcome, such as, for instance, death, in the example that I'm going to show, is preceded by potential risk factors, and they should be measured in advance, ideally, and then it will be unbiased in terms of the outcome. Usually you can't measure risk factors after death, but you could after, say, retinal detachment or something like that. A cohort study can be either prospective or retrospective. A retrospective study is much more efficient, but you might not have the same quality of data, and it totally depends on sort of a fortuitous availability of some documentation from which you can harvest all of the data. And that's the model that I'm going to present. A prospective one is sometimes done, like the multi-center AIDS cohort study is a very famous one, where patients are enrolled and just followed over time. But it takes an awful long time to get the information with that approach, whereas the retrospective one is faster, although it isn't that fast because it's rather difficult to do. And usually, unless the follow-up is really close to complete, which doesn't really happen with people that have lives and have other things to do than participate in a study, then survival analysis is going to be the backbone of statistical analysis because it's flexible to assess losses to follow-up. And this method assumes that events are irreversible. So let me say more about that in a second. So survival analysis is a time to event analysis, and the statistics studied are the duration of event-free follow-up time, and then at the end of the time, what happened, if they died or had a retinal detachment or something, or were sort of the study with their follow-up was stopped without them having the event. And usually the sort of statistics you see are a rate, so like an incidence rate of the complication or the outcome, a Kaplan-Meier curve sort of graphing the risk over time, and then Cox multiple regression, which it's called, let's see, like semi-parametric survival analysis, allows you to adjust for potential risk factors. Poisson regression can also be used in certain circumstances. And I won't say any more about that, but these are the kinds of things you would typically see. They said in one assessment that maybe 35 to 45% of all New England Journal articles were using this kind of analysis. So it's important to have at least passing familiarity with it. The event ideally is irreversible. So death is sort of the prototype, irreversible except for a few miracles reported over the years. But sometimes we will use it to look at things like vision loss, and vision loss might not really be irreversible. In fact, in uveitis, it's often reversible. And so sometimes we sort of try to make it relatively irreversible by saying it's sustained for a period of time, or else we can just say it's the incidence of sort of having a reduction in visual acuity, which might have improved later, something like that. And so anyway, there are some limitations then with if it's not an irreversible event. And as we said, it's extremely useful for dealing with losses to follow up, but those that are lost are supposed to be the same as those that are followed, which may not always be completely true. Like in a tertiary uveitis setting, a lot of patients who are doing well might stop making the long trip to Boston or something to be seen for follow-up, and they might be doing better than the others. All right, so this is the most famous paper so far. We we'll publish another one shortly about longer-term follow-up, and I'll present the results from the new paper that's not published yet. This is a study we called Systemic Immunosuppressive Therapy for Eye Diseases Cohort Study, nicknamed SIGHT, to make a pun on vision, although it's not really much about vision, but rather about survival. And there's a lot of collaborators. Basically, we took some of the pioneer immunosuppression centers for treating ocular inflammation, and then sort of my center also when I moved to Penn. And then in the site 2, we added additional centers to get more information about TNF inhibitors. And so we'll talk about that in a minute. It was funded by National Eye Institute and some other funding. And so the problem that provoked me doing this study and the collaborators was that immunosuppressive therapy has an important role for preventing blindness from eye inflammation. And when I was a fellow in 1997, we were told you need to do that. But I was saying, well, is it really safe to do that? You know, people ask if they're going to get cancer from drugs like methotrexate that was first used as a cancer chemotherapy drug. And that wasn't really that clear. People tried to talk about it based on rheumatology, which it wasn't that clear in rheumatology either at that time. So this had limited some patients from accepting the treatment, even though it's really safer than using prednisone, say. And so our primary goal was to evaluate the long-term safety of these treatments more thoroughly. So we completed sort of the first grant of this, and I'll tell you the design in a minute, but this provided pretty convincing evidence regarding the safety of antimetabolites and T-cell inhibitors. That was this paper back in 2009. Hard to believe it's been that long. And at that time, we had 5 to 7 years median follow-up for mortality. So if you're going to have a mutation caused by the drug, slowly develop cancer, you know, be treated for cancer and then die, it might take longer than this. That's sort of a limitation that we had. We also had some concerning preliminary data about TNF inhibitors, like a barely statistically significant association with increased death and mortality, or death and cancer death in this, even though the median follow-up was only like 3 years. And so this kind of didn't make a lot of sense. And so we didn't emphasize it too much in the report, and then we wrote another grant to study it better. And there was some suggestion there would be increased cancer mortality risk with alkylators from this, but it wasn't significant. So we set out then with the new grant to clarify issues regarding the TNF inhibitors and then to provide sort of longer term follow-up for the other immunosuppressants. And we also have been evaluating cancer incidence, which is still incomplete. It's been quite a nightmare to complete that study. It's taken 5 years to complete the cancer registry linkage, which was just done completed a few months ago. So I'm going to present the primary mortality results here, which I haven't published yet, although I have presented it at ARVO and Academy. So the general design, as we said, is a retrospective cohort study with 5 main US clinical centers that were tertiary uveitis centers, and then 5 more what I called ancillary centers that were also tertiary uveitis centers, where we just looked at TNF inhibitor treated and then a matched control patient in order to sort of enrich that amount of exposure to TNF inhibitors, which was sort of specific aim 1 of the project. And so we were looking at potential risk factors of use of TNF inhibitors, antimetabolites, T-cell inhibitors, and alkylators on the outcomes of overall and cancer mortality. We looked at anterior, intermediate, posterior panuveitis, and then also scleritis pemphigoid that had ocular involvement, and then sort of an other category like inflammatory optic neuropathy, other kinds of cicatrizing conjunctivitis, orbital inflammation. Not too many of those were there. And they had to present to one of the participating centers. And the study period was sort of from the inception of the center until with Site 2 through 2010, inclusive. For the other centers, the ancillary centers, it was sort of from 1999 when TNF inhibitors became available until 2010. We excluded people that had infectious ocular inflammation as their primary diagnosis, people with HIV, And we included them in the study if they had cancer, but we didn't include them in the mortality analysis. So we obtained our data from sort of a gigantic chart review, which took more than 20 person-years of time to do. So it was a huge task. And we had a standardized protocol to ensure quality as well as we could. We sort of followed the rules, and we collected data about every patient at every visit, and even every eye of every patient at every visit, including medications like immunosuppressants. As you may know, in the US, there's a national registry of death certificates, which would include Puerto Rico as well. And this is used to generate the National Death Index, which is an epidemiological tool which provides near perfect matching for ascertainment of death when there's a Social Security number available, which we had in about 80% of our patients. And it has about 90% sensitivity and specificity for match based on name and birth date. So in this, we queried from 79, which was the first year of the death index, and also approximately, I think Foster started it in 78. But for death, we looked at this period, which happened to cover the period when all of our centers were operating. Through 2013, it's kind of taken me a long time to publish this because of other challenges, mostly related to being in Ethiopia and trying to start the center here. And this also provides you an excerpt on cause-specific mortality based on the death certificate contents. And we use that just to look at cancer. Like if you have something like heart attack was the cause of death, you might mix it up with something caused cardiac arrest or something, but with cancer, it's pretty obvious. So those is where our primary outcomes come from. And we can get this even if the patient has left follow-up. And so it greatly enhances our perfectness of observation. It's near perfect since people get a Social Security benefit if they file death in the United States. And we looked at the person time following exposure to each of the immunosuppressants or class of immunosuppressants and compared it to person time where the patient hadn't been exposed to any of them. So like some of them would be censored, for instance, if you're looking at TNF versus nothing and the patient went on cyclosporin, after they went on cyclosporin, we wouldn't follow them for mortality. And we used survival analysis like promised. We used a Cox regression adjusting for factors I'll show you in the next slide. And we looked at 3 and 5 year time lags where we sort of excluded the first 3 or 5 years of follow-up time, thinking that it would take time to have effects from the immunosuppressants. And so we looked at it sort of all 3 ways, as you'll see. And we also did it both including and excluding patients with systemic inflammatory disease, which are often associated with a higher risk of death. So these were the factors we adjusted for: demographic factors, smoking, a well-known cause of death, the site of ocular inflammation, which was more like just we wanted to control that, not that we thought it would be likely related, and it wasn't. The Charlson Index, which is a risk of death based on a comorbidity score, where you get points according to what comorbidities you have. We didn't have that many comorbidities in this one. And then presence of specific rheumatological diseases selected by the model, like granulomatosis with polyangiitis, formerly known as Wegener's, which is a strong predictor of mortality. So looking at the characteristics of the cohort, once we had the Site 2, we had about 16,000 patients. So this is sort of about the biggest ocular inflammation cohort in the world. They were followed for an average of 10 years for mortality, a range, the interquartile range. So 75% had at least 6.6 years and 15.8% were 15.8 years for 25%. So from the 25th to the 75th percentile, making a total of 187,000 person years. So a little bit more than that times that, because there were some followed very long. And then about 2,000 died during that time, and about 4,300 died from cancer. And so if you subdivide this into those who never took immunosuppressive therapy, which includes some time from people who later went on immunosuppression, there's this many with about 8.7 person years median follow-up. So it's a little bit less because some of them went on to some other immunosuppressant after that and continued to be followed. And then these are the ones that were treated with each of these categories of drugs. So there's pretty long follow-up for all of them, even for the TNF inhibitors, a newer one, with nearly 10,000 person years for those, and then more than 10,000 for the others, over 40,000 for the anti-metabolites, which are our most common drug. So if we look then by the category, the TNF inhibitors were the ones that we wanted to look at the most, since it looked like they were associated with higher mortality in the first study, and they seem sort of like a wonder drug, and in rheumatology they don't seem to be associated with higher mortality. So once we had more follow-up, we didn't see any association. So if you look at them as a category, you know, it was no difference from the unexposed people in terms of the risk of death, and with lags it's about the same. If you look at the major subtypes, all of them seem to be close to 1, or, you know, tending to be better than 1, but none of them significantly different from 1. So a hazard ratio of 1 means that the exposed group and the unexposed group are the same. If it's less than 1, it means the exposed group is better. And if it's more than 1, it means the unexposed group is better. So if these cause mortality, it should be a lot more than 1. If we exclude the patients that had systemic inflammatory disease, which is the majority for this one, because it's hard to get the super expensive drug without a comorbidity until the last few years, which was after the site studies time period, you still see the same thing, basically. You're not seeing an increased risk. We were tending to have a higher risk with the etanercept, which was mostly from the site 1 time, and this was probably what was tending to show the result that we had there. But here it wasn't significant, excluding patients with systemic inflammatory disease or including them either. So this sort of affirms that the TNF inhibitors were safe regarding these outcomes. We see similar findings for antimetabolites. You know, this is really important because these are the main drugs that we're using, and, you know, all of them are close to 1 and actually a little bit less than 1, not significantly less though. And doesn't matter if we use lags or not. And the T-cell inhibitors for cyclosporin, the main one we use, you can see it's 1 basically. If you exclude people with systemic inflammatory disease, it tends to look a little better. We had seen a signal with tacrolimus here, and I think that this is mostly because we didn't capture transplant status in the study, unfortunately. And so this might have been a marker of transplantation, although this one might have been too, and you don't see the effect there. So this is sort of like the TNF in the first one, you know, it raises questions, but it's, I don't think, very convincing that it increases risk. If you look at the alkylators, we see that there is an increased risk of mortality with all of them as a class, and with cyclophosphamide specifically. Chlorambucil has hazard ratios that are the same or higher, but a smaller sample size, so it's not significant. So this is sort of along with what we had hypothesized. But then if you take out the systemic disease, it's a little different, because you'll remember this drug is given to people with conditions like GPA to save their life. And so those patients have a higher risk of death. If you exclude those, it's actually not significant and close to 1. So that was kind of surprising to me, that we're not really affecting their mortality if we're giving this for eye disease. And then we'll get to cancer now. So looking at cancer death, we see basically similar results to what we saw for overall mortality. No increase in risk with TNF inhibitors, no increase in risk with antimetabolites. With mycophenolate mofetil, we're almost significantly improved, at least with all the person time. And remember that this drug was a blockbuster because it reduced cancer in the transplant scenario. So it's kind of looking, it's certainly not increased, I guess, is a good way to look at that. And we have a pretty big sample size, but you know, maybe with more power, we would be showing it was actually reduced. With T-cell inhibitors, again, we're not seeing an increased risk of cancer death, which was a real possibility because it's supposed to be carcinogenic, according to the authorities related to WHO. We had done another paper where we thought this was causing like a sort of interaction with predisposed people to sort of release, especially Epstein-Barr virus causing transplant-related, what is it called, where basically the Epstein-Barr virus infected cells get out of control, like mononucleosis is sort of an infectious cancer, and the immune system controls it, but if they're immunodeficient or immunosuppressed, it might get out of control and cause lymphomas. But we didn't see that in aggregate for all cancers. And if we go on to alkylators, again, we're seeing there's tending to be a higher risk with this without excluding the people with systemic disease. Excluding the systemic disease, it didn't come down that much, but it's still not significant. So maybe we're seeing some cancers here, which we would kind of expect from sort of smaller studies, but not a huge effect and not statistically significant. So this is kind of encouraging regarding alkylating agents. And just to summarize then, for total mortality, this is a so-called forest plot, which you'll usually see with evidence-based reviews. But for TNF inhibitors, you see no effect overall or in any of the subsets. And this is looking at overall and cancer mortality. Or I'm sorry, that's not correct. It's looking at with systemic disease patients and without systemic disease patients. Same thing for antimetabolites, calcineurin inhibitors or T-cell inhibitors, and that alkylators are elevated, but not if you exclude the systemic disease cases. And for cancer death, sort of similar results all along. We tried to look at some, sort of, if there was some cumulative dose threshold for, like if you exceeded a certain threshold of cumulative dose, you'd have a higher cancer risk or death risk, but we didn't see that. Or a maximum dose rate, we didn't see any association at all. So this suggests then that these drugs are not causing death or death due to cancer. It's actually probably better than a rheumatology study, because rheumatology conditions can cause death and are associated with cancer in some instances. And the worst cases are going to be the ones that get these drugs. And so they might have an indication for treatment bias, where the drugs are being given to the ones at the highest risk, but that's not true for the eye disease. And I didn't show you standardized mortality ratios, but the risk of death is not higher. In fact, it tended to be lower slightly than the general population in our cohort, especially when excluding systemic disease. We can avoid this methodological problem. And we had a good sample size. We could adjust for individual level risk factors, and we had excellent ascertainment of both exposure and cancer, or an outcome. So we had less information than we would like for these two drugs, and it would be nice to study this one more, although I think it's going to be difficult to get funding for that. We had a good duration of follow-up, including for the TNF inhibitors now. We do have incomplete exposure ascertainment after the patients left clinics, but if the drugs were causing death, that would mean that we ought to see higher risk in the exposed, like it should be mitigated, or that there should be some association even without, and then it would be even worse if there was less exposure, but we didn't see any pattern to suggest that that made a difference. And then we have incomplete ascertainment of confounding. So confounders are factors that cause the outcome and then might be more frequent in one of your covariate levels of interest, like using immunosuppression. And so maybe people that use immunosuppression are more likely to have some factor that we don't know about that increases the risk of death. But again, since we're getting negative results, it's not likely that that was important. So a clinical trial avoids this problem, as we'll see in a minute. Alkylators look better than in the site one. And it's true that increased cancer mortality or increased cancer is supported by some prior reports from other disease conditions. And there's a rationale for that, especially for skin cancer, blood cancers, and bladder malignancy with cyclophosphamide. But our results do diminish the sort of overall concern with these, and said that if it's indicated that this would be reasonable, although these are tending to be used less now that biologics are available. Tacrolimus should be studied more, and etanercept wasn't really very strong, and we don't really use this drug anyway. so it's not that important for us. So the data support the long-term safety of most commonly used agents with respect to mortality and cancer mortality for all the major antimetabolites, cyclosporin and TNF inhibitors. So basically for all the drugs that we use frequently, we confirmed that this was safe. It also provided us a giant cohort of patients in person time and eye time that could be applied to a wide range of questions. For those of you going into academic medicine, if you can sort of get your own cohort, it's sort of a great way to publish a lot of papers. And so from this study, we have 37 publications so far, and we have about 10 in process right now because my sort of production time is lengthened a little bit being in Ethiopia. But anyway, we'll hopefully have a lot more out in the next 2 years. So this has answered a lot of questions and actually provided about 1/6 of all the so-called best papers of the year selected by the American Uveitis Society since that program began in 2009, because it's just applying outcomes research from the largest cohort. And I sort of designed it so that we would have information about all these things as we began. So we had an awful lot of information. All right, now going on then, and I'll try to talk a little faster to cover everything. You can look at risk factors. So this is just an example of a site study where we applied our database to assess the incidence of cataract. This isn't published yet, but it should be before long. And so cataract is important. It's a leading cause of visual impairment. It is reversible, but we would like to avoid it because you lose accommodation forever in younger people. It has relatively good outcomes with surgery. We'll sort of see how good at the end of the talk, but not perfect. And so prevention of cataract is sort of an important goal of uveitis management that you should really think about every time you see a uveitis patient. And so we looked at cataract based on a visual acuity definition where they were worse than 20/40 or 6/12, and it was blamed primarily on cataract. And we used this for the risk factor analysis because the other definition was occurrence of cataract surgery, and we artificially suppress activity of inflammation before we operate. And so you can't really study the effect of inflammation itself on the risk of cataract for as a risk factor. And so we wanted to do that, and it is a risk factor. And so risk factors, we're using this definition, but the first of these two is used for absolute risk assessment. So again, you use survival analysis with a cohort kind of study like this, measure incidence, estimate it using Kaplan-Meier method, use the statistical methods I talked about. If you're looking at an eye-specific outcome, you have to adjust for the fact that eyes of the same person are likely to behave more similarly than eyes of other people. And so there's sort of simple ways of adjusting for this using statistical packages. Although if you're not a professional statistician, it may be difficult for you, but you can find a collaborator to do that. And you can also look at time updated values, which I didn't mention before, but you can actually look at sort of bits of time where people have something like active inflammation, AC cells or something, and then other time when they don't. Separately, you sort of bend those into two different categories, the follow-up time. And so you can look at exposures in a very precise way, you know, and not just sort of what it was at the beginning and how they did 5 years later. So looking at this, this was a subset that had anterior uveitis. We also have looked at this in intermediate uveitis, which has just been accepted. But in this one, we have about 9,000 eyes of about 4,500 patients, and about 12% had primary anterior uveitis, about 50% recurrent, and about 40% chronic, sort of reflecting the group of patients you would get at a tertiary center. You know, these get referred, especially these, and the primary ones usually are presenting primarily to your institution and you get them that way. So, you know, we probably have 50% like this, 25% like this, and 25% like this, as you'll see later. And we had 773 cataracts, but only about 310 by the visual acuity definition. So this is looking at the incidence over time using a sort of Kaplan-Meier curve where it's just estimated at certain time points rather than the typical step-like pattern. And this is a 95% confidence interval. So you can see by 5 years, we're getting to about 25% having cataract. And by 15 years, it's getting to be, or 16 years, I guess we get to about 40% have had cataract and 60% haven't. And so it's a pretty high amount of risk, but most patients are not getting it, and this is only going down to 40% on the graph, because otherwise you can't see the detail well. When we look at risk factors, age is a risk factor. That's not a big surprise. Even being sort of over 45 was a risk factor, which is kind of surprising. Thankful that I don't have a cataract yet. Race and ethnicity, we didn't see much effect. I think in population studies, African Americans tend to have more opacities, but not necessarily opacities causing vision loss. Sex and diabetes were not significant in this data set. Diabetes would be a risk factor in population studies, and this does tend to be higher, but it's not significant in our data set. Smoking is thought to be a risk factor, but we showed it a little higher, but not significant in our study. Now, if we start looking at the time-updated anterior chamber cells, we see that in the crude and the adjusted analysis, there's a dose-response relationship. So the more inflammation you have, the more cataract you get. And this is mitigated by adjusting for other factors, but it's still following like a dose-response relationship with more and more risk the higher it is. So this is bad for you, and bad in many ways, but also including cataract. If we look at the type of anterior uveitis, the chronic one has the most risk, and the recurrent ones where there's long periods of remission have less risk of developing cataract. Since we have more data for recurrent, that one's statistically significant, but it's looks like it's even less in primary, as you would expect, because they're not going to have that much experience of being inflamed. And if you look at glaucoma surgery, that increased the risk. That's a known risk factor. And then uveitic things, band keratopathy is a risk factor, more than double the risk of cataract. This is probably sort of capturing a lot of history of inflammation. So probably this captures some of the inflammation that isn't captured by a time-updated analysis like this. And then we looked at posterior synechia, and this is strongly associated with an increased risk of cataract. And we saw this with intermediate uveitis too, which included both sort of limited to intermediate and then anterior plus intermediate. And I think that this reflects a mixture of sort of inflammatory severity in the past, plus like mechanical pulling on the capsule of the lens continuously every time the iris moves that might increase the risk of cataract. So this was a strong risk factor. If we look at IOP, very high IOP in a time-updated way is a risk factor. We know that people can get glaucoma flecken from this, and maybe that might proceed to cataract. And then if we look at topical steroids, if we don't adjust for other factors, we see sort of a dose-response relationship. But if we adjust for other factors, it seems to kind of never go above about 2 after you get to 2 drops. And even with 1 drop, it was tending to be higher risk of developing cataract in the sort of time-updated way, looking at sort of what the value was, whether they were taking topical steroids at the visit before the one at which you ascertained the cataract had occurred. If we look at periocular injections, it's a much higher hazard ratio, but we didn't show significance with 1 or more of these. We have another study about outcomes of periocular steroid injections where it does seem to be higher if you get like 3 or 4 injections. And systemic corticosteroids tended to be higher as well, but not significantly, and it interestingly didn't really differ according to whether it was low dose that we sometimes use for maintenance therapy or higher doses. And so, but it probably is increased risk, but maybe not as much as eye drops that are above 2 or 2 or more for most. Now, we wanted to look at sort of the mixture, so-called interaction between the anterior cell grade and the eye drops. And so we found that if you have 1+ anterior chamber cells, you have a higher risk. And it doesn't really matter what your dose of eye drops is. But if you have grade 0 anterior chamber cells and you have 1 drop a day or less, then you don't seem to have an increased risk. This is a hazard ratio of 1, 2, etc. If you have 2 or more drops a day, though, with 0 cells, then you have a higher risk, about double. And if you have sort of minimal cells, it seems like even with 1 drop, it tended to be higher, and not really too different if it was 2 or more. And so getting the eye quiet is very important for cataract, and limiting the drops is also important, but that's the second biggest thing, although you might still be wanting to use techniques to avoid causing, to lower your topical steroid dose. So we have various limitations. I'm sort of seeing the time fleet by, so I'm not going to talk too much about them. And we have a lot of strengths with sort of a really big study where we could look at time-updated associations. And so we found then that age, current activity of inflammation as measured by anterior chamber cell grade, approximating the standardization of uveitis nomenclature approach, which was sort of based on the opinions of our participants largely, was a strong risk factor. And then severity factors, prior glaucoma surgery probably has some mechanical effects too. Posterior synechia and then topical steroids were risk factors. So all of these can contribute. Now, in some cases, we can alter these predictive factors. And so these are opportunities to reduce the risk of cataract. And so we're trying to develop a point system. We haven't quite finished this yet, but this is where we're at now. And so the ones highlighted in yellow are things that we could potentially prevent. Band keratopathy may be present before we get there, and so we might not prevent that in people who already have it, but we might prevent them from having it if we're treating them going forward. Like I haven't seen too many people that I'm managing for JIA, juvenile idiopathic arthritis, uveitis, develop band keratopathy. And so anyway, we could prevent that by good treatment. We can potentially prevent synechia by good treatment, and maybe even breaking the synechia might help if with dilation, if we believe the mechanical theory as part of the mechanism by which that might cause cataract. We can control IOP and hopefully avoid wild spikes, which aren't always avoided, unfortunately, in uveitis management. And then we can control inflammation, and we can use a limited number of drops. And so if we have 1+ or more, then you have a higher risk no matter what the drops are, but we try to get both down. If you look at according to this point scale, which includes some things you can't alter like age, if you have minimal points, you have a pretty low risk and you're getting out to 20 years with only a 25% chance of cataract. Whereas if you have 5 or more points, you're having the majority developing cataract by about 8 years. And so these people have a real high risk. And if you could move them to one of these other categories, it reduces the chance of cataract a lot. So this is when we get this finalized, I think would be a useful tool for managing patients. It's important to remember that it's better to control inflammation than to avoid topical corticosteroids, but you want to use as little as you can, and using like oral sometimes might have less risk, which also has less risk of high IOP. And you'll see from the MUST trial that it didn't really have high risk of side effects if you do it right. So cataract is frequent in anterior uveitis, but not universal. Posterior synechia may have a uniquely high risk increasing property, and judicious management can reduce the risk. So, so this has important implications for how we manage patients, and also is a good example of how you would use a cohort study to identify risk factors. All right, moving on then, we'll go on to treatment efficacy and the example of a clinical trial, and I'll give the example of the MUST trial, which is sort of the most famous trial I've been involved in. And so what is a randomized controlled clinical trial? So it's really a cohort study. It's just like a cohort study where you enroll patients, you collect data on their potential risk factors, and then you follow them for the outcome. The difference is that one or more of those potential risk factors or covariates, we actually assign it to the patient. And so we hopefully randomly give them treatment A or treatment B. Sometimes we do a factorial design where we give treatment like a 2x2 table of treatment A and B versus treatment C or D, like the age-related eye diseases study is a famous example of that kind of design. And so this is always prospective, not retrospective, because you're assigning the treatment. And the analyses are similar to a cohort study. And you can also sort of look at side issues like a cohort study, like cataract in the site study. But this study is enormously difficult to implement because there's huge regulatory barriers. Like I'm working on a clinical trial now where we're like 18 months in, partly due to COVID, but and we still don't have approval to go ahead with this sort of trivial risk study. And then there's a lot of ethical burden because you have to make sure that you're acting in the patient's interest. And sometimes you can't design a study where you randomly assign treatment and have it be ethical. You have to have so-called equipoise where people as a community agree that either treatment is equally likely to be better than the other. So it really only has two advantages over a cohort study. And one is to avoid indication for treatment bias. So usually in clinical practice, you give the more strong treatments to the more severe cases. And so like if you're looking at cyclophosphamide versus people that didn't take an immunosuppressant, you're probably going to see that unless cyclophosphamide is spectacular, that the patients are going to do worse because they are more severe cases. And so you avoid this with the randomized trial. And then also, if you have a good size study, you can have the confounding variables will on average be distributed evenly between the two groups. And so, and this is nice because there are some things you might not know about that cause the outcome, and those are still going to be distributed equally. I've used some studies where we use some fancy statistical methods to try to overcome this, which we can sort of partly do, but you can't overcome this except by randomization. And so because of these advantages, then the FDA and other regulatory bodies typically require this kind of study to approve a drug, and usually they want two of them that show reasonable evidence of safety and efficacy. And like I said before, there's, it's easier to show efficacy with this than it is to show safety, because usually you can't follow enough patients for long enough to show this except for very common side effects. And so this is a very important kind of trial and is regarded as level 1 evidence in the Oxford evidence level scenario. And but it costs probably like 50 times as much as a cohort study. Like the MUST trial, I think, cost about 12 times as much as the site study, even though it only enrolled about 250 patients and the site had, 17,000 patients. So that it's much easier to do chart review than to follow patients prospectively and protect them. So that's how that goes. So this is our most famous paper from this study. And this was published in 2017, and we'll see what the results are. And this is, I'm pasting in here my Retina Subspecialty Day presentation about this. And so this was sort of a team effort. The site study is also a team effort, but it's sort of mostly led by me, whereas here there are many people involved. So this sort of began with Doug Jabs having the idea for a comparison of steroid implant versus systemic therapy, and then me sort of running with it to try to make it happen. We recruited Mike Altawheel from the University of Wisconsin Reading Center and Janet Holbrook from the Clinical Trials Unit in the Johns Hopkins School of Public Health. And then later on, Elizabeth Sugar joined a little bit after we had gotten started, and Jennifer Thorne also, she's a statistician and she's another uveitis specialist. And there's about 500 other collaborators. So there's twice as many collaborators as patients in this study. So this was motivated by the question then, which is better, a fluocinolone acetonide implant known as Retisert or standard systemic therapy, sort of according to an expert panel group that had published a paper in 2000, of which Doug Jabs was the first author. And at the time we began this study, we thought, ophthalmologists are surgeons, and they're going to feel much more comfortable with a surgical approach for managing uveitis rather than all of this fussing with rheumatological methods and checking labs and titrating doses and so on. It's a big headache when you can just do surgery. So we thought, everybody's going to gravitate to this treatment. And the clinical trial that was done for FDA, or the two clinical trials, were sort of unusual ones where they were kind of comparing activity of inflammation after treatment with what had happened to the same patients the year before treatment, which is sort of a weak design. But the treatment was so spectacular in controlling inflammation, there was little doubt that it worked. And but we were like, well, which is better, because this had a lot of side effects, it looked like too. And then would implant have a role as an initial therapy? Should this be first-line therapy, or should sort of what had been first-line therapy before for intermediate posterior and panuveitis be what we should do? So we did a sort of standard clinical trial. We had 23 centers, mostly in the US. We randomized 1-to-1 by patient. So like if there are 2 eyes, if they get implant, it's going to be implanted in both eyes because systemic therapy is given by patient. And we stratified by intermediate versus posterior panuveitis. Stratification is a strategy to make sure that the patients in different strata are balanced in the 2 treatments. So we thought intermediate uveitis cases would do better than posterior panuveitis cases, which has been clearly shown subsequently. And so that way you get balance across that, and then clinical centers might behave differently. And so you want them to be balanced and having sort of an equal number of both treatments. We followed them up at least semi-annually. It was more often at first. And at 2 years, we finished our official trial and published sort of no difference in the primary outcome, sort of better control of inflammation with implant and more side effects with inflammation. And then we went on to a sort of observational follow-up study, sort of cohort study, following randomization, where most patients continued their same treatment that they had been assigned. And we'll go through what we found by 7 years. So these were our inclusion criteria. Basically, they had to have active or recently active intermediate posterior panuveitis without contraindications to either treatment. And so with the implant, we followed what you're supposed to do with implant therapy that Glenn Jaffe had developed along with others. Quiet the anterior chamber to less than 1+ cells before doing surgery. 1+ cells or more, he had the impression that hypotony occurred in those cases. And then implant the implant, gradually taper and discontinue any systemic therapy, and then replace the implant when and if the uveitis ever reactivated. This is just showing the implant compared to some popular current or popular coins. So it's a pretty small thing to cost $8,000. You make a full thickness eye wall incision, put it in. There's a suture that goes through the little hole that you suture into the sclera, and then it stays there. It could be removed surgically, but it doesn't have to be removed. So it's sort of a permanent thing that stays in the eye unless you remove it surgically, which isn't really a dream to do. The systemic therapy was, I think, what Armando has been teaching you about, using oral steroids to what I call induction to induce control of the inflammation, and then using immunosuppressive therapy if they can't be controlled at a very low dose of oral steroids, if they had certain diseases that usually need immunosuppression, or if the steroids fail to ever gain control of the inflammation. And about 90% ended up getting immunosuppression. And we sort of followed this sort of consensus paper method for managing this. So we ended up enrolling 255 patients with 479 uveitic eyes. The treatment allocation was approximately balanced. And by 2 years, we had pretty good follow-up, a little bit over 80%, if I recall correctly. And then we went on to the long-term follow-up study. We lost a few more, and we got to about 70% that made it to 7 years, which is a little bit less than you would like. But the people that lost for follow-up, that were lost and had only minor differences between them that weren't statistically significantly different. So it's probably a reasonable outcome, and JAMA accepted it, so that was good. All right, so to understand the results, you have to start with activity, even though visual acuity was the primary outcome. So this is sort of the number of months since randomization. So you see the implant had better control of inflammation. This is sort of saying active or not. So you could have very minimal inflammation and it could be, graded as active. But anyway, implant was clearly better. The systemic was sort of gradually getting better over time. And that's probably because we're constantly tweaking it to try to get better control. And so up to 4 years or 4.5 years, the implant was better. around this time, we began to have implants running out. And so then there were some relapses. And so by 6 years and 7 years, there was no significant difference between the two treatments in the overall average inflammation. If you look at the visual acuity then, which is the primary outcome, this is a so-called box plot where this is the median, this is the 25th and 75th percentiles, and this is the 95th and 5th percentiles of the distribution. So the visual acuity in the conventional way is over here. So the average patient enrolled around 20/40 with some really bad vision and a few that are better. And over time, both groups, implant and systemic, tended to retain their vision. And so like at the time we did the first MUST publication, it's pretty similar. We did a 4.5-year one, and again, it was pretty similar. But when you're getting out to 6 and 7 years, you see that it's getting a little bit worse in the implant group, and especially in the tail, like the distribution is disproportionately towards the bad vision compared to the other group in the implant group. And so by the time we got to 6 and 7 years, then we have a statistically significant difference. And so this was suggesting that the systemic therapy approach did better. So we got criticized about this because people said, well, you should have replaced the implant and people might have done better. As you'll see, the implant patients had quite a lot of side effects, and many of them didn't want to have it replaced. And you have kind of a logistical problem about how if you've not had any activity of inflammation for almost 6 years, you know, is the insurance going to pay for that? You know, which is something like $20,000+ per eye to replace it. And you know, it was supposed to only last this long, but it lasted longer. So are you going to replace it here? You know, so it's kind of difficult to replace it, which is often overlooked. And if we were treating with systemic therapy and there was no activity for 2 years, we'd be tapering off the therapy. You know, so I think it's a fair way to do it, but you know, other people disagree with that. So we assume that this drop in vision happens because of sort of severe reactivation. They can have ultra severe relapses when the implant runs out, apparently. And so some of them got scars, and that seemed to be mostly from retinal scars, like macular scars, that this difference happened. But the difference isn't very much. It's like 7 letters, like 1.5 lines. So in my mind, you know, this group is doing really well. To lose 1.5 lines on average for these severe cases after 7 years. But the systemic group is doing better, where they're actually at least as good at 7 years as they were at baseline. And I think it's often overlooked that if you can be as good after 7 years as baseline, like it's going to take a pretty good treatment to displace this treatment, especially when you see there aren't many side effects, which we'll see in a minute. So looking at the side effects then, basically intraocular pressure and then glaucoma itself as graded by an outcomes committee are all much more common with the implant than with the systemic therapy. And surgery is extremely common, like 40% needing surgery within 4 years. And so all of these things are more common. I guess I didn't reformat this to the 15 or 16:9 format, sorry, but all IOP and glaucoma problems are much higher with implant, 40% needing surgery. And then looking at other sort of systemic therapy complications, they're not significantly different between the two groups. They do tend to be a little higher in systemic, but it's nothing close to a significant difference. And if you look at the sort of immunosuppression side effects, I'm sorry this got moved up a little bit, I guess as I switched to the 16:9 format, but none of these are different. And the one that's closest to different is actually higher in the implant group, you know, which is probably just random variation. And so we're not seeing a lot of systemic side effects. The only thing we did see was infections. This is supposed to be over the infection here. Hospital or infections requiring treatment, which might have just been oral antibiotics in most cases, were higher with systemic. But you know, more than half of the implant patients got that too. But it is a significant difference. Now, I'll just tell you in interpreting this, if you go to your primary care doctor and say, well, I'm taking immunosuppression and oral steroids, then they're a lot more likely to give you an antibiotic, I think, than if you say, well, I'm not taking any medications. So this may just be due to a bias, but it was significantly higher. And so we acknowledged that side effect. We didn't see any differences in cancer and death, which we're not really powered to assess. And surprisingly to me, there weren't any differences in weight. Like I would have thought that these patients would gain weight in the systemic group, but that didn't happen. Although they were on average pretty heavy when they enrolled, so maybe they had already gained weight. Still, it was impressive that there was no difference there. So this had a number of limitations. The main one that people complained about is we didn't replace implants, like I said, and that we had multiple looks. Although when you see, when you see a p-value of 0.006, this is not going to be, if you penalize this for multiple looks, it's still going to be significant. So there were a number that crossed over. And so some of the systemic patients, I think 20% got implants eventually. And so really the 7-year outcome is sort of like starting with systemic therapy and advancing to implant if you need it. And there were also 20% crossovers the other way, that they continued with systemic therapy because for whatever reason, they didn't want to continue with implant. And one other thing that isn't that clear from this presentation is about 40% of the implant cases never did reactivate again within 7 years. So that was an interesting observation. So our conclusions are that better vision and less side effects support systemic therapy as first line in most cases. And I think this has largely been accepted. And it's important to note that the implant treatment had good outcomes. It's just a little bit less good, and it's a lot more expensive. The safety profile was remarkably good from the systemic perspective, which sort of is good news for rheumatology. And also the implanted eyes remained quiet for much longer than 3 years that it was supposed to be, usually reactivating at 4.5 to 5 years and about 40% never reactivating. And so there's clearly a role for implant for the severe cases. Like there's some cases that you never control with systemic therapy, and these are usually controlled by Retisert. And so there's a role for either rescue when you fail systemic therapy, and possibly you could somehow discern some cases that are just going to do badly. Like for instance, they may be, very severe diabetics or something, and dealing with steroids is impracticable. So the problems seem to arise in relation to relapse. So if you could predict when relapse was going to occur, then you could maybe reimplant. That this is not easy to predict and not easy to get by insurers. So just thinking about methodology then, this sort of, I think, concluded the final thing that systemic is first line and that implant is useful as a second line treatment. But it also provided another large cohort study, and this is much smaller than the site study, but it has sort of much better prospective information, like with serial imaging at the same time of everybody, whether they needed it or not, and sort of super optimal methods. And so we've been able to publish a lot of papers from this as well. And this study has the second most AUS best papers of the year. So between the two, they provide a lot by having these sort of, NIH-funded long-term studies. Both of these studies we began in like 2002. I think the MUST we began in 2001, December, working on the grants. And, the MUST is pretty much finished now, but we might have a couple more papers come from it. The site is still going, and we just got a new analysis grant for some more papers. So anyway, these have a big impact beyond their specific aims. Okay, so this is taking longer than I thought, but Armando told me that I could take more time if I wanted to. So let me go on to sort of burden of disease types of studies and risk factors from population studies. And I haven't done as many of these personally, although I have done one, and I'm just working with Hilkia, who's over here, on sort of putting this together as a paper. So if we think about clinical epidemiology applied to burden of disease and population risk factors, we want to do a population survey, like I mentioned. So the key is that the study be population representative. where everyone in the population has a known chance of being selected. And so this usually starts with a census. It's often a government census, and then you might move on to randomly select certain administrative units. So we're considering doing a study like this in Ethiopia now, and there's 11, I guess 9 regions and 2 sort of cities that count as a region, like the District of Columbia does. And so you would select these, or perhaps have a stratified selection within those, and then you randomly, you sort of order all the towns and villages within each area and randomly select them with the probability proportional to size. There's a compact segment approach then, where you get to the ones you pick, where you basically just go there and like spin a wheel and kind of walk in the direction the wheel points and select each house until you have enough. You can do this in even a small, relatively poorly funded study, or you can do it in a very expensive way, like the Beaver Dam Eye study. And these studies are extremely lucrative in terms of the number of papers you can produce. One of my classmates from public health school and public health ophthalmology, Tien Wong, you might have heard of, from Singapore, he's publishing like 100 papers a year doing this. So my record is 26. So that's really something. You perform a questionnaire and do an examination, hopefully, using robust methods to diagnose the issues of interest. And so like the National Health and Nutrition Examination Survey is a famous one sort of across all diseases in the US that's been done repeatedly. And the Beaver Dam Eye Study, Baltimore Eye Survey, there's lots of them that are eye studies, which have been very productive. And if you can follow them up, you can convert this into a cohort study and estimate incidence. So you can really only get prevalence from sort of an initial survey. And so these studies are pretty hard to do, except for the so-called rapid assessment of avoidable blindness, which has been designed to be sort of like a prevalence survey in a container or something that it sort of walks you through how to do it. And so people have done, I think, over 200 of these now, mostly in developing countries, where it's sort of a very limited study, but it has good population sampling. So it's a cross-sectional study unless you do a follow-up and make it into a cohort study. And if you do it as a cohort study, you're still really just looking at 2 points in time, so you can't really do survival analysis. You're going to look at proportions and odds ratios and use logistic regression as your statistical methods. And you may need to adjust for the design effect, because not everyone in the population is going to have the same chance of being sampled. And ideally, you would sample like the whole country, or in theory, you could do the whole world. And that would be the most generalizable, but it sort of depends why you're doing it and what population you want to generalize the results to. And like I said, it has the potential for a massive number of papers, because you don't even, like with the site, it's all like ocular inflammation. So here you can do macular degeneration, you can do cataract, you can do refractive error, you can do anything basically that you have a big enough sample size for. Ron Klein, who with his wife Barbara were the principals of this study, even like was invited to give a talk about the incidence of like impotence or something like that. So, I mean, you can write a paper about anything that you have the foresight to collect data on. So I'm going to just present the results of some of these and what it means for uveitis. So for uveitis, it's not that susceptible to this kind of study, because usually you can't get a sample size big enough to study diseases with a prevalence of less than 1%. So usually it's around 5,000 is sort of the point of good return. If doing more than that, you have to probably do 50,000 to do something with the prevalence of uveitis, and so it's not really feasible with a brute force population survey. So there have been 2 population surveys, which were both at sort of the super centers in southern India, and I participated in one of those. So I think I'm going to skip it though, because it's not that exciting of a study. So people have tried then to get information from other studies like administrative databases and health maintenance organizations like Kaiser, which are sort of a natural cohort study, where you know when everyone enters and you know when they leave, and they get all their health care in the system in between. And so some have also looked at like government systems where there's a subspecialty center in Paris or something like that, and everyone from the region of France goes there if they get uveitis, which has some weaknesses because not all of them really go. national surveys based on self-report, like you might be able to get that for some diseases from NHANES, not uveitis though, unfortunately. And then insurance databases have been a big thing, like this Optum database. And then people are trying to use things from electronic medical record databases to look at outcomes type of studies, but that's not prevalence and incidence. So if we look at what we know about this for uveitis, here's a summary of some studies that have been done in the West to look at the prevalence of active uveitis in a 1-year time. So a 1-year period prevalence, they had activity of uveitis per 100,000. So it seems to be sort of around 75 or 80 per 100,000 are going to have active uveitis within a given year. And these are all different studies. This one and this one from Kaiser, this one from Veterans, and this was more like a regional referral center thing and a sort of highly socialized medicine thing where they had a lot of records. And then from the Optum study. If you look at the Optum study in children and adults, you see that children have a lot less uveitis than adults. And the overall was here. And this might have been higher because this is just based on codes that people entered, and they might enter that they have uveitis when they have postoperative inflammation or something like that. From the studies that were true population-based studies, and this is looking at the prevalence of sort of signs of having had uveitis or active uveitis, it was about 730 per 100,000 in Andhra Pradesh and 270 per 100,000 in Tamil Nadu, which was a study I was involved in. If you look by the site, it's overwhelmingly anterior uveitis, little intermediate uveitis, and then more posterior and pan uveitis, but this is sort of where 80% of the disease burden is. Fortunately, these are the ones who do the best. If you look at sort of who presents where, you'll see mostly anterior uveitis presenting to general ophthalmologists, and this is Gary Holland's practice, where everyone in Los Angeles is referring to him. And so he's a cornea specialist too, and so he's probably a little bit more anterior than others. We had around 50% in the site centers, but 50 to 60% are going to have anterior uveitis still. So it's still a lot of what you deal with as a specialist. Now, Nisha Acharya's study from Kaiser in Hawaii looked at how many presented with primary uveitis, recurrent uveitis, and chronic uveitis, and it's sort of about 2 to 1 to 1 here. There were some she couldn't tell. So this was kind of more chronic than I thought. So there's a good number of patients with chronic anterior uveitis, and we saw in the cataract study that they do worse, just because they are always having to be on treatment or else have activity. If we look at the incidence of all kinds of uveitis, this seems to be around 25% per 100,000 per year, and we have a little bit more studies here about this. And so it's not a common disease. It's just the patients often stay with you forever. So then, this is probably what we would say for risk. And all of these might be underestimating a little bit because they pretty much rely on passive methods of ascertainment. So people that are mild cases just might not ever come in, or in poor places, they may just not be able to access care, but those are going to probably be the mild cases. So they may be less important in a way. And the proportion who have had uveitis at some time in their life would be quite a bit higher, as we saw in the South Indian studies. And probably there's going to be more uveitis in tropical areas because a lot of tropical infections can cause kinds of uveitis, and our studies are all from temperate regions in the West pretty much, except for one from South Africa, which is also temperate. Now, what about risk factors? So we get on to the risk factor issue in the population for the development of uveitis. And so some of these population studies, the ones from Kaiser, showed an increased risk with age. And so, maybe higher age means you have a higher incidence of developing uveitis. If you look at intermediate and posterior uveitis from the California study from Kaiser, it tended to drop off for at least the intermediate and posterior. And in Proctor, they tend to call what the Sun group calls panuveitis diffuse uveitis. So that's more or less panuveitis. So maybe you have more of a bell curve with an age around 44, and this is kind of what you see in tertiary practices, is that kind of distribution. If we look at the proportion who are female for the two Kaiser studies, it's not that convincing, except in children, that it's more in females based on the population studies. In the tertiary centers, you do have about 2/3 or about 60% female. And so maybe with the more severe cases, you're a little bit more likely to get it if you're female. The Northern California study happened to be in a place where it's almost an even distribution of races and ethnicities. And I don't think that David ever published this. I couldn't find it when I looked preparing for this talk, but he presented a poster about this, and that the African Americans had higher incidence of uveitis than the other groups. In Hawaii, the white people had the highest incidence, and then Asians had less, and Pacific Islanders had less than that. And so, maybe African Americans have a higher risk. Working in Ethiopia, I've realized, as I was also told by others before, that Africa is extremely genetically heterogeneous, so generalizations like this are probably not that valuable, really. But people talk about this. Now, there have been some studies, and I've been involved in a couple of them, about vitamin D, low levels of vitamin D, which has been of interest for all kinds of inflammatory diseases. And it's been reported that low vitamin D levels are associated with higher risk of uveitis in general, of Vogt-Koyanagi-Harada disease particularly, and this is reported in both Black and white races. And there's some lab data to support the sort of pathogenic mechanism by which that might happen. So vitamin D levels might be a risk factor. Female hormonal therapy, I was not the PI, but involved in a study like this, and it seemed to be like a slightly increased risk of having uveitis, but probably not enough to deter you from using birth control pills, because it was very rare. And then there are lots of reports about drugs associated with uveitis. These are not so much epidemiologic studies for the most part, but more reports of clusters. The ones that I've highlighted in bold are very frequent to get uveitis, and then the ones that are italicized are sort of well known, and you might see it in your career. The others are quite unusual to develop uveitis, and so I'll just give you a second if you want to take a photo of that, because it's kind of hard to digest. Like, you have 2 whole review articles about this. Anyway, drugs can be a cause of uveitis too. So if we summarize, then older age, soft data that it's a risk factor for higher risk of uveitis. This was reviewed in chart review, so it wasn't just cataract surgery causing that. Soft risk, soft association with female sex and female hormone replacement. Smoking, I didn't find epidemiological data very much, but it probably at least has a higher risk of activity in uveitis cohorts. African American race, maybe. Vitamin D deficiency, probably, and certain drugs are risk factors for developing uveitis. The lifetime risk might be in the range of 1% or more, and it might be higher in Africa, but again, like we say, Africans are really very genetically heterogeneous compared to Asians and white people, and so we don't really know. And then because infectious uveitis is probably more common in tropical, less developed countries, the burden is probably higher there. If we extrapolate on the estimated burden based on the prevalence of 75 per 100,000 one-year period prevalence, then we would see that in the US, we may have 250,000 people that have active uveitis in a general year. Probably this is about a year ago, so a little more now. In Europe, about 500,000. In the Middle East and North Africa, about 280,000. In Sub-Saharan Africa, probably about 800,000, maybe more if the risk is really higher. And globally, about 5.6 million, like 5 2/3 million people with active uveitis in any given year. And if we look at lifetime risk, if we assume it's 1%, you're getting up to 75 million people. So a pretty big chunk of the population in a disease that's very treatable, although a little bit harder to treat than cataract, say. Now, what about vision loss from data like this? So we have pretty limited data about this. Bob Newsenblad and Sue Lightman both said about 10%, but sort of not with very good quality data, and maybe reflecting experience from years before steroids were available, where it was untreatable and most people had severe vision loss that developed it. And maybe it would be even higher in developed countries where there's more infections at a higher burden, and then a lot of cases may be neglected. So the impact per case, however, is probably higher than for age-related disease because it's tending to happen at a younger age, so there'll be more years of preventable vision loss, but it's probably an order of magnitude less than the sort of big ones like AMD and cataract and so on, so it's still not quite measuring up to that, although it's probably more treatable than glaucoma. So anyway, I kind of think that this is underappreciated in the global health world. And the cost of controlling it, both in terms of money and energy, is considerable. So if only the Sandra Pradesh study directly estimated this, we actually did directly estimate it in the Aravind study too, but there were so few, it wasn't really very useful. So they had a fair number that had significant vision loss, 160 per 100,000. There tended to be a lot of macular scars, probably from toxoplasmosis there, so other areas it might be less. But if we assume those numbers, we would see like 20 million people worldwide having low vision and about from blindness. Would you be able to get my cable from by the couch in there? Okay, so vision loss is substantial in tertiary referral populations and probably throughout the world. And although the severity is in the general population is much less than tertiary centers, uveitis is thought to be the 5th to 7th leading cause of visual loss in developed country populations, and maybe even more in developing countries where most don't get treated. And the impact might get better over time as treatment is scaled up. And it has a higher impact per case than age-related eye disease. And so we need to train people to avert this, because in fact, most severe vision loss is unnecessary, probably, because with treatment, people actually can do pretty well. So most vision loss is either temporary, like from macular edema, or at least is sometimes temporary, or cataract, and some people may avoid it, as we saw in the MUST trial. So, you know, here we're seeing, I just plug it in there, that people retain their vision for 7 years, even though severe cases of intermediate posterior and panuveitis that were willing to be randomized to surgery or immunosuppression, basically. And in the SIGHT study, we saw over a 5-year window that most patients initially got better and then were stable over time, except the posterior maybe had some choroidal neovascularization cases and sort of went back to their baseline. So the average patient is not losing their vision under tertiary care. So this was impressive. If we look at, and we published this, if we look combining SIGHT and MUST, we see that looking over time at estimates of gain or loss of 10 letters with a time to event analysis, a lot of people have that, either loss or gain, and sometimes both. So time to event, this is a limitation then of the survival analysis with a reversible outcome that, you know, obviously a lot of them are getting better. The dark shade is supposed to be SIGHT, and the, actually I can't remember which is which, but anyway, dark and light are SIGHT and MUST. And so you see that actually there are more patients that got better over the first 5 years than got worse by 10 letters in both of those studies. And we looked at some risk factors in SIGHT, and we see that sort of the longer you take to get to tertiary care, the worse you do, especially if you have cataract surgery before tertiary care. It's about 3 lines worse than the average patient in SIGHT, whereas if you have surgery during tertiary care, it's about 3 lines better than the average patient in SIGHT. This might be exaggerated because the bad outcome might have been the reason to be referred, but still that's a pretty big difference. And probably cataract surgery should be done under the supervision of a uveitis specialist. And then we see that activities related to reduced vision with different activity parameters in a dose-response relationship. So these studies show that the average patient with uveitis is stable, might even get a little better with appropriate care. And so it has substantial benefits then, and we need to educate people all over the world to manage this. So that's my little pitch for uveitis management. So if we can follow the consensus kind of approach to this, we can have results like in the MUST trial. That's pretty difficult for people that aren't specialists, but if you can sort of know when you've reached your limits and refer to a specialist, the patient should be able to have good outcomes in much of Latin America. There are specialists available. Okay, I'm going to skip the example study because I've already talked for an hour and a half, and there's some more interesting stuff. All right, the agreement studies then, I got involved in this because it irritated me that we're grading people, you know, as like 1+, 2+, 3+, that nobody really knew if these were reproducible assessments. So I looked into this. So an agreement study is assessing the degree of agreement between two observers where neither is the gold standard. So like between two uveitis specialists grading anterior chamber cells. We can calculate simple agreements, a kappa statistic, which is a way of looking at agreement beyond what would be expected by chance. Because some people just by, like if you roll dice, you know, you'll roll 2 dice, you'll get agreement some of the time. And then you can do like a weighted kappa where you give sort of partial credit for disagreement that was close but not quite perfect. And then interclass correlation coefficients are a way of looking at this for continuous variables. So we can also look at compared to a gold standard. And so this is like the sort of laboratory testing paradigm where you're looking at sensitivity and specificity. I'm not going to give an example of this, which is a little bit difficult to study in uveitis, but these sensitivity, which is the chance of the test being positive if the disease is present, and specificity, the chance of the test being negative if the disease is negative, these are intrinsic attributes of the test. And then positive and negative predictive values are like what you really want to know in the clinical situation, like what's the chance that the patient has the disease if it's positive. And so these are going to be the same in any population, but these are going to depend on the pretest probability. And so like if it's extremely unlikely that they have the disease, you know, for instance, if you're doing COVID testing and somebody who's just recovered from COVID, if it's positive, it's going to be a false positive, and it doesn't really matter that the sensitivity and specificity are very good for COVID tests. And there's some mathematical things like this. You can, if you're able to estimate the chance that they have, that a uveitis patient has sarcoid, then there's a likelihood ratio associated with getting a chest x-ray that's a function of sensitivity and specificity, and you can calculate the probability that they have sarcoid based on the results of your test. And ideally, it either rules in or rules out the presence of the test, although unfortunately we're not in that situation always in uveitis where it's completely ruled in or out depending on the result. And so this kind of assessment requires that you have gold standards, which is not always true in uveitis. So this was then the question that annoyed me. So I eventually did this paper. So the, you know, the MUST trial and follow-up study and the site study have taken like 15 to 20 years to do, almost 20 years, and millions of dollars, I think tens of millions of dollars for MUST. This study I did during a week-long trip to India, and so we just got people from LV Prasad Eye Institute, from Shankara Nethralaya, and from Aravind Madurai to line up a lot of uveitis patients, and then I just graded the patients with each of them, and we looked at our agreement. And so this was then to sort of test the Sun working group method of grading cells and sort of site of inflammation. And we wanted to determine the reproducibility of gradings of the anatomic location, so anterior, intermediate, posterior pan, and to determine the reproducibility of gradings of like anterior chamber cells, flare, vitreous cells, and vitreous haze. So we just graded the patients one after another live, and we had reviewed the criteria in advance. We had vitreous haze standard photos available, and we sort of did a training period like you would do in a clinical trial, because sometimes these outcomes are the outcome used in a clinical trial, and so they should be reproducible if they're going to be meaningful. And we graded vitreous cells, vitreous haze, and the site of inflammation with the pupil dilated. So in this paper, we didn't do it at LV Prasad because they were too busy, but we went and did that later in a better way with the subsequent paper. And we calculated the kappa statistic, and this was based on some sample size rationale. So to review about the kappa statistic, this is sort of a rule of the thumb. about how good the agreement is. And you want to be almost perfectly in agreement for something to be robust, and some things unfortunately don't have much agreement. And so we looked at this different ways. So for anatomic site of inflammation among these categories, this is a drawing that Doug Jabs had made, which I'm using courtesy of the MUST research group, showing the different sites of inflammation. And so we found that we had exact agreement as to what site of inflammation, and only 68% and 57% with the two pairs of graders, and a kappa value of 0.6 and 0.5, basically. So, pretty good, not really great. So it's interesting, we're enrolling patients in trials with only pretty good agreement as to what their site of inflammation is. And these were good uveitis specialists. I think this was fairly soon after the Sun paper came out, and we, I guess, invented anterior and intermediate uveitis as a category. And so that was confusing to a lot of people. And so if we excluded that, it was a little bit better, 0.7 and 0.6 agreement. So, getting up to substantial agreement if we did that. So not too bad, but not as good as you would think. If we go on to anterior chamber cells, this is the Sun grading scheme, 0, 0.5 plus, also known as trace, 1 plus 2 plus 3 plus 4 plus. And if we looked at exact agreement with this, it was only about 0.4 kappa that we would both say it's like 1 plus or 3 plus or something. But if we say it's within one grade, like one of us says 1 plus and the other says 2 plus, then we're getting into super good agreement. And then the Sun group had advocated that it would be a significant improvement or worsening in inflammation if there was a 2-grade change, or else if it went to 0 or 4 plus, like the ceiling or the floor or the ceiling. And with that, it was a lot less good, but it was still pretty good agreement. So just within 1 grade, so that implies then that a 2-step difference would almost always be noticed by either one of the reviewers if there's only if we're agreed within 1 grade. So this kind of influenced thinking a lot, this simple study and people using this for trials. If we look at flare, we see something similar, but the problem with flare is that everybody is sort of in one of these 3 categories, unless they have fibrin in their anterior chamber. Like I almost never would grade someone 3 plus where I can't see the iris because there's so much haziness, because I still can see the details. In Ethiopia, I'm seeing more of this, but in the West, people are usually in these 2 categories or else have none. And so if you're saying within 1 grade, you can just grade everyone 1 plus and you'll agree with everyone on that. And so that was kind of what we saw here, but you can see that the confidence intervals are really wide because everybody's 0, 1, or 2. And this one is not used much in, I think if you have a flare meter, you probably have much better agreement and you can detect differences much better. So otherwise we don't use this much. With vitreous cells, the Sun group never came up with the real system. Like there's sort of 2 predominant systems of looking at the clefts in the anterior vitreous and looking if there are cells there, which is sort of the one that I use. And then the retroillumination and just sort of see how many cells you see, which is sort of the Newson-Blatt fellow way of doing it. And there you can't discern if the cells are just some sort of object that hasn't been digested, and it will look the same as a true cell. So anyway, we couldn't come to any agreement about how to grade vitreous cells at the Sun meeting. One approach that wasn't formally endorsed was just could we say they're absent or present? And so I tried to look at that, and we had sort of moderate agreement with that. So it sort of supports that we don't really have agreement about how to grade this. And so this is needed to be done. If we look at vitreous haze, this is sort of the classic NEI system that Newson-Blatt and colleagues developed in the 80s. And from perfectly clear to completely opaque, and then grades in between. Like here you can barely see the fundus and just the first order branching of the vessels. Here you can barely see there's some haze, and then these are kind of in between. And So it's sort of similar spectrum to the anterior chamber cells. And here, if you looked within 1 grade, I was only able to do this with Rothinum. And so if we look within 1 grade, we're getting to pretty good outcome. And this was actually kind of used by the FDA for a number of trials. So it's interesting, you know, I had a lot of impact with my colleagues for the site and the MUST, but this one had a pretty big impact when it was just a 1-week trip to do the whole study. But it makes sense that you need to know that something is reproducible before you can really use it as an outcome. And it makes sense to look at inflammatory markers for uveitis treatment, because the treatment's going to affect inflammation and only affect vision sort of secondarily by controlling inflammation. And so this proved to be a pretty important outcome. We did this a little bit better in a subsequent trip to India, and this has been pretty widely accepted. So let me kind of move on here. Now, as a last example, evidence-based review is an increasingly popular kind of methodology to study, where you synthesize data. I guess this was meant to be evidence synthesis, and you use evidence-based review and meta-analysis to incorporate data, sort of share strength from several studies in order to answer a question. And so the Cochrane collaboration has been sort of the leader in this, and they have all kinds of publications about how you ought to do it. And I was, for a few years, the editor-in-chief of Ophthalmic Epidemiology, and we rejected just evidence-based review after evidence-based review because people didn't follow the directions. And so if you want to do this, make sure you follow the directions. Ideally, you should have a published protocol beforehand. It might just be sort of registered with the Cochrane group. And then you want to have like a scientific method for how you obtain the articles that would be reproducible, just like any experiment. And so a lot of people kind of try to do this, but it ends up being more like just a review article. Now, the Cochrane group puts emphasis on clinical trials only and omits everything else. And if you are interested, there's a sort of tongue-in-cheek article that was published in British Medical Journal, which I should have put on the slide, called Gravitational or Parachutes for Gravitational Challenge. And they were kind of trying to make a point about some of the limitations of this method. But the idea was, well, there aren't any randomized controlled trials of parachutes for gravitational challenge, and so therefore we can't have any conclusion about whether parachutes work or not. And so, you know, this kind of points out that you do have evidence about things that aren't clinical trials, and you need to use that. And that's especially true in uveitis because we don't have that many clinical trials. Like MUST has proceeded to point about uveitic macular edema, and MERIT, which is still in progress, and ADVISE, which is still in progress, about TNF versus conventional immunosuppression. And then there's a number of drug licensing trials now. So we have, you know, some clinical trials. We had only the implant ones, I think, when I joined, other than like CMV retinitis and toxoplasmosis trials, and I think maybe one Bichette trial. But most of our evidence is from other observational studies like sight and sort of experience. And so we need to look at that if we want to make any conclusions for smaller areas. If you want to do a evidence-based review, I would suggest reading this article here that 2 of our board members from Ophthalmic Epidemiology wrote, sort of about what we wanted in order to publish it in Ophthalmic Epidemiology. It's only like 3 pages, so it should be easy enough to do. So in brief, the methods call for a standardized search to cast a wide net for potential papers of interest, a manual review to see if inclusion criteria for papers are met, usually starting with a review of the abstract, which gets rid of most of them, and then a review of the whole paper. And then ideally, you harvest the primary data from them, like some people will call around and ask people to submit their data, and then you can just analyze it like it was one study, which is only really valid if all of the inclusion and exclusion criteria were the same, which is seldom true. Or else you can put together summary results, like if you say, well, the proportion that had a 20/40 or better outcome of cataract surgery was this, you know, which is what we used in the example I'll show you. And usually this is presented as a forest plot, which I'll show you here, and we had also used for the site mortality analysis. So I was motivated to do something about this because we're always telling people they'll do fine with cataract surgery, but at least if they follow our instructions and wait until the uveitis has been quiet for this arbitrary amount of time of 3 months, and we provide good subspecialist supervised medical management, which makes a huge difference in my clinical impression. But what are their real chances? And so we tried to answer this in this paper that was done by, at the time, a resident and a medical, or I think a pre-medical student that we did. And we didn't publish, I'll have to confess, we didn't publish a protocol before we did it, so we probably would have gotten rejected. But anyway, in those days, the bar was lower, and I still think the results are valid. So our goals were to estimate cataract surgery outcomes in a way that could guide our practice. And so we used this paper as reference by Neil Poe. He's actually a nephrologist, but there was an evidence-based review group at Hopkins, which I participated in some of their things. And so they found that with normal cataract surgery until about 1990, about 96% had 20/40 or better visual outcomes. So that's kind of like our bar of what somebody would have if they didn't really have anything wrong with their eye. This, I think, did include some mild AMD cases, probably, like you can't exclude everything. But in general, the outcome is super good. This was with mostly extra cap, I think, at that time too. So maybe phaco would be better, I'm not sure. And so our questions were, what are the outcomes of cataract surgery in patients with uveitis? And we divided this into some sub-questions. So we did a systemic literature review and meta-analysis following the Cochrane methodology and PRISMA published guidelines for systematic reviews. And we reviewed these databases. It should be as wide as possible, especially these two. And this was the search strategy. I won't trouble you with it, but it's all explicitly done in a reproducible way. And we wanted studies that contain patients with uveitis undergoing cataract surgery or eyes with uveitis undergoing cataract surgery. And they had to report the proportion that ended up 20/40 or better. And so you'll imagine that this is a little bit limited because, like, we might operate on a patient with a macular scar and we know we're not going to be 20/40 or better, and they might have their life completely changed by obtaining navigational vision, but we weren't able to do a meta-analysis with that. I'm trying to do a site paper about that. We're going to be addressing this with this new grant that we just got the other day. And we included them too if we could calculate the proportion 20/40 or better from the paper. So we excluded conference abstracts, non-English language, because we couldn't understand it. Intracapsular surgery we thought isn't really relevant anymore, in very small series and combined cases. So this usually generates a vast number of articles, and the trainees usually get stuck reviewing all of these. So first there were 32 duplicates excluded, and then reviewing the title and abstracts, we cut it down to about 10% because a lot of things are about something completely different. And then reviewing the whole paper, we cut it down to 86 papers that addressed the questions. And then we found another 3 by reading the papers that we had missed with the search. So this is how it's usually done. So our first question is, what are the outcomes of cataract surgery in patients with uveitis, or the big question, what proportion get 20/40 or better? So if you look at phaco with an IOL, it was about 70% in a fairly narrow amount, combining the data from all these studies. It ranged from, I guess, 46% to 88% of cases. And again, these are not necessarily bad outcomes. Like, people might have a macular scar and they're not going to be 20/40 or better. But that's sort of the chance of being 20/40 or better with phaco. Now, what about with extra cap? So with extra cap, it was basically the same. We had not as many data, but we had a pretty tight confidence interval on this. And so it was 72%. So it doesn't look like it's worse than phaco. There's a strong sense in the field that phaco is better, and everyone pretty much agrees to that, but the published literature 10 years ago didn't really support that. So I don't really feel bad doing extra cap or manual small incision cataract surgery on my patients here in Ethiopia if phaco isn't feasible. We looked at pars plana lensectomy, and we had a lot less data about this. And also, these were cases where, let's see, I can't remember if it was these or these, but a number of these cases were operated hot, operated active. And so overall then, they had a pretty poor outcome, getting the proportion 20/40 or better. But if you think about it, you know, these patients all saw a retina specialist. So if you see a retina specialist, that's sort of a poor prognostic sign, like you have something wrong with you, usually if you're going to a retina specialist. And so that might be a bias, but that's still kind of a low number, especially when it's sort of a more difficult surgery. And so this looked like extra cap and phaco were better than this. This was, I think, a really hot group where it was like without consideration of being quiet, but still not that good in the ones that were quiet. So it looks then like extra cap and phaco are probably better if it's possible. There might be some reason to do lensectomy, but a lot of retina people will now just do a phaco and then they'll do the vitrectomy afterwards. So the second question was, what about with or without an IOL? So Howard Tesler tried to do a randomized trial about this actually in like 1980 or something. And he ended up having to call it because no one would enroll because everyone wanted an IOL. So that probably tells you something. But a lot of case series and, you know, if you would say cohorts, brief cohort studies have been published about this. And so the ones with an IOL basically have the same outcome as the other two summary ones of phaco with IOL and extra cap with IOL, about 70% being 20/40 or better. And so they seem to do pretty well with IOL. The ones without an IOL did worse, but you have to think that this is probably, you know, it was withheld in more severe cases, but it did tend to be withheld sort of in older times. In older times also, the treatment might not have been as good, although places like Foster's practice, I think, were doing pretty state-of-the-art time and Tesler's practice at that time. And so, you know, probably there's some bias here. But the main question is like, you know, you wouldn't leave out an IOL unless it caused harm, you know, so it doesn't look like it's causing harm compared to leaving it out. So this is why we use an IOL in nearly all the patients. There was a long time in JIA cases where people hesitated to do it, but I think with TNF inhibitors and perfect control, people are doing it mostly now. Again, the hot eyes are, you know, doing worse as we expect. And so it looks then like IOL is indicated for most cases. So how about types of IOL? So there was an effort to make a heparin surface modified IOL. I think it's mostly stopped being made because acrylic seems to be just as good. But looking at acrylic, again, you're getting around 70%. So basically what you're getting with cataract surgery and uveitis cases where you have some with posterior uveitis that have limitations from macular scars or advanced glaucoma or something like that. If you're looking at heparin surface modified, it was about the same, so it doesn't seem to meet the bar for a big advantage over the lens that most people use for most cataract surgeries. And if you looked at sort of regular PMMA, maybe a little bit worse, but not a lot worse. And you know, maybe it's older studies where people weren't as particular. If you look at silicone, it seemed to be a lot worse, and that kind of surprised me. There's not much data, but anyway, the silicone didn't look like it was as good. So it seems to support acrylic basically as a good material among the options that were available at that time. And then does the outcome differ according to the type of uveitis? And so Fuchs, there's lots of publications about this, and you can see that the Fuchs with a pretty narrow confidence interval looks like it does better on average than uveitis altogether. And so this is what people have said. It's still not quite as good as the Poe study for sort of normal age-related cataract, but they do pretty good with this. And usually people don't make them quiet. It's thought that you don't need to do that for Fuchs. For JIA, maybe a little bit less good, but not much less within the sort of, you know, relatively early postoperative outcome. You know, so this isn't like 10 years later. And I I think people think these patients can go downhill, but now with TNF inhibitors and so on, they actually do quite well. And so they're not necessarily doing as much worse as people have thought in terms of visual acuity. And again, if you quiet them, it's sort of about average. If you leave them active, then they do really bad. Intermediate uveitis was sort of similar to uveitis in general. The TET disease was worse, probably because the people with, intermittent ischemic necrosis caused by inflammatory vasculitis, wiping out parts of the retina, just don't see as well. Again, with treatments like TNF inhibitors and interferon, probably they could do a lot better now. So overall, then, we reached those conclusions I kind of gave along the way. Now, if we think about this methodology, the limitations are that individual level data usually aren't available. And so you can't do adjusting, so if you have some confounding, you can't address that very well with meta-analysis unless you have exactly the same protocol. Like we tried to put together 2 protocols about difluprednate that were used for direct licensing, and there you have like exactly the same protocol. So you can combine it nicely, but usually you can't in an evidence-based review. And in this study, these were observational, not trial, except for that one Howard Tesler study, which was only about 20 patients. So then that's a limitation. You might have indication for treatment biases, and some of the indication for treatment biases I mentioned as we went through. And the decision, again, maybe how to do it could be related to the severity of the disease. So a randomized trial would be better. Older reports also might affect less ideal practices than followed in more recent times, because we're all kind of arrogant and think we do it better than the people of the past. But that may be true to some extent anyway. And then there could be publication biases. And this is a big problem for evidence-based reviews. Like if you get a terrible result, you may not publish it. Or if the result is the same as what someone else published, then you may not get it published. And then you're not really getting a good sample of all the studies that had.
Voy a escribirle a Dr. Kempen, creo que ese fue un segundito.
Capaz se le cortó la conexión.
Sí, deme un segundito que le escribo ahora por WhatsApp. I think I lost you. Internet. We'll wait for you. Ok, le escribí por aquí. Él está en Etiopía ahora mismo, debemos escribirle aquí. A veces la electricidad ya se va, él me dijo que si se iba, que esperáramos 3 minutitos y él regresaba. Ok, perfecto. Que regrese en 3 minutos. Así que esperemos por él.
Puerto Rico es igual que Etiopía.
Sí, estamos, parece que sí.
Estamos ahí. Ok.
La verdad que he aprendido una cosa increíble. Ahí está. There's John. Hello. Good. Good, awesome.
I was just finishing.
Don't worry. Take your time, There we go. Okay.
All right. So acrylic is probably your best bet for uveitic cases until someone develops a better lens. And then Fuchs has a better prognosis than everything else. You don't want to operate on active eyes, and I think everyone realizes that. And an anterior approach to cataract is probably better than a posterior approach, but there might be certain instances where the retina specialist knows better. And ideally we would do better studies to look at this. I think Doug Jabs is trying to do a trial now about alternative steroid treatments perioperatively, for instance. All right, to summarize then, we gave examples of population survey type studies, risk factors from population studies and from cohort studies. We could also have done a case control study where you look at bad outcome versus good outcome, and then look at risk factors that have been ascertained beforehand or according to the patient's memory, which is less robust to look for risk factors for bad outcome or for good outcome. We looked at an example of agreement statistics with kappa. You want to do kappa a lot for like clinical trials where the outcome is based on a reading center or something, to make sure that people are in good agreement about grading the outcome, or degree of anterior chamber vitreous haze, inflammation, and uveitis. Diagnostic test stuff we didn't get into much, but this is pretty important. You can think of COVID examples for that. Clinical trials, ideal means of assessing whether treatment works or not, but not as good for safety because you don't have enough experience to detect the rare events. Safety and sort of risk factors for a good clinical outcome can come from a cohort study especially, or a case control study. You could also use to look at that. And then evidence-based review is supposed to provide the highest level of evidence, but it depends on having good inputs. So like the example I gave you didn't have clinical trials, and so the inputs weren't really quite perfect, and you couldn't really address if the patient had a good result, but just whether they were 20/40 or not, whether or not you expected that. And so in a future site paper, we'll look at like how many lines of improvement they had, whether it was from sort of 1/200 to 2200, or whether it was from 2040 to 2020. The first one might have a better benefit from cataract surgery, for instance. So just in terms, for those of you who might be thinking about doing research like this, to do a large scale study like CITE or MUST, you basically can't do it without funding, especially with trials, because the organization like the IRBs and regulatory organizations like FDA will insist on really good, perfect compliance with patient protection and regulatory compliance, and you just can't do that in your free time after your clinic. I've seen a couple of toxoplasmosis treatment studies, like giving Bactrim for prevention of relapse of toxoplasmosis, done in Brazil, that I think were done without funding. But that's only because the treatment effect is so dramatic and the treatment simple that they were able to do that and have a significant result. But it's almost impossible with a trial. So you need funding organizations to do studies like CITE and MUST, which I've been am thankful to be the beneficiary with my colleagues of having such funding. But smaller studies like the agreement one and the meta-analysis actually could be done, and were done, the examples I gave you, without any funding, other than just covering travel to go to India or something like that. Okay, so that's it, and I'm about 30 minutes over what Armando had asked for. This is just a picture of where I'm sitting now. I'm just like right on the back of this place here, and this is our hospital here and the eye clinic right here. And so after 5.5 years, we have a pretty reasonable and just about self-sustaining eye service here. It hasn't quite reached Aravind proportions, but hopefully over time will grow. Aravind wasn't that big after 5 years too, although they were going faster than us. Probably partly because it's harder here and partly because they're just better than us. Thank you very much.
Thank you so much, John. This has been amazing. I learned so much from so many topics, and I'm sure the residents did as well. That's been amazing. I hope to have you every year, and I hope that sometime in the future we can bring you over to Puerto Rico to teach us live.
Thank you.
So much better to have you teaching, and in the academy we get 10 minutes of you, and today we got over 2 hours. And by the way, welcome to Latin America. This is what we expect. If we give you 1.5 hours, you're supposed to talk for over 2 hours. That's true. So that's amazing. Now, I think some of the residents had some questions. Eduardo, do you have a question, or was it somebody had a question? Was it answered already? Okay, and just one of my residents asked me a question, and he was wondering about the wait before cataract surgery, because we always teach 2 months. You mentioned 2 months. Do you have any data on that, and whether 2 months or 3 months is better?
Yeah, we tried to look at that in a site analysis that was never completed and should be completed under the new grant now. And we found really not that amazing data to support the university agreed practice of waiting for 3 months. At least it's not worse. So it's not really that's really a consensus based concept. But I don't know, in practicing in Ethiopia now, where you see a lot of neglected cases with really a lot of scarring, like probably what Stephen Foster was seeing at the beginning when he was sorting out how to manage uveitis in the US. In that kind of situation, it's probably more difficult, you know. So if you have like recurrent acute anterior uveitis and it's quiet again, you know, it's probably not quite the same as if you have, you know, chronic panuveitis with all kinds of peripheral anterior synechia and so on. You know, those kinds of cases, I don't think you want to neglect waiting 3 months. And I think, you know, if you think about just what's in the best interest of the patient, if it might benefit them and it's not going to cause them harm, you know, waiting 3 months could be a good option. Like if they're totally blind and, you know, you're going to say, well, even though you're quiet now, I'm going to leave you blind for 3 months, bilaterally blind, you know, then you might be a little more flexible if they had a good prognosis. But most of those cases are going to be severe cases, and maybe you're still going to want to wait 3 months because you want them to not be blind for the next 40 years. So.
Yes, you know, I always have a story. I had a patient from Somalia, actually. She had history of TB, abdominal TB. I treated her, she had been treated, and then the infectious disease specialist told me this is not TB any longer, so I gave her CellCept, but I couldn't get her quiet. So, and she went all the way down to LP. She became a United States citizen while being LP vision in both eyes. I waited. I called the infectious disease specialist and said, would you mind giving her an alternate treatment? Maybe this is resistant TB. So he did. She became quiet, and we waited the 3 months of quiescence, and she was 20/20. So that's the beauty of waiting. So eventually you get those great outcomes. Which is,
I don't think that people
Yeah.
appreciate it. You know, people are always talking about cataracts, you know, because you have sort of a very fast outcome. But I feel like we benefit uveitis patients here at least as much as cataract patients. You know, I haven't systematically done it, but we have an awful lot of big successes where people are going from terrible to really good. And many of those do involve cataract surgery also, but some of them, you know, are going from like bilateral exudative retinal detachment to 20/20 outcomes.
Wow.
There seem to be a lot of VKH cases here, more than we had in Philadelphia.
Wow.
And so, you know, I think people underappreciate how much benefit uveitis management provides, and just sort of how wonderful steroids are if you can avoid their side effects.
Have you seen any seasonality to your VKH in Africa? Have you looked at that? We just looked at that, and we found a huge peak. Actually, Eduardo is here. He found a huge peak in November, and we just ran the statistics. We didn't know how to do it, and we did a 4-cell analysis like last week, and we found it was actually statistically significant for fall. Low numbers, but we're going to try to publish that. So it's, and you were talking about vitamin D and all these other issues. So it's quite interesting.
Yeah, I imagine vitamin D should be a bigger issue in Boston than in Puerto Rico, but
of course.
But maybe everyone's wearing sunscreen in Puerto Rico. So.
Oh yes, we're inside, you know. So I'm going to ask in Spanish if they have any questions they would like me to translate, just to make sure nobody's being shy. ¿Alguien tiene alguna pregunta para Dr. Kempen que quiera que yo le traduzca, que quieran hacerle? ¿O están bien? Okay, so no questions. That is, John, thank you so much. Oh my God, this has been amazing. It's gonna be a tough act to follow. I speak now of intermediate and posterior uveitis, but thank you so much for being with us.
Oh yeah, you're welcome.
For being part of
I'm
the
sure.
Pico Basic Sciences course.
Thank you. I'm sure they'll
God bless
appreciate
you,
it more since you'll be in Spanish.
Oh, yes. But the
All
slides
right.
are in English. That's the part here in Puerto Rico. It's
Yeah. All right. Well, blessings. Good to meet you all.
God bless you, John.
Thank
Bye-bye.
you, and you too. All right. Bye-bye.